All right, future nurses, welcome. In this explainer, we're getting laser focused on the must-know neoplastic disorders for your pediatric ATI exam. I'm talking straight from your ATI review module, chapters 39 through 41, to get you prepped and feeling confident. Okay, you ready? Let's dive in.
So right out of the gate, here's a question that is pretty much guaranteed to pop up in some form on your exam. What you do, or maybe more importantly, what you don't do, when you find a painless abdominal mass in a young kid, well, it's a massive patient safety issue. We're going to get to that answer in just a minute.
Okay, so here's our game plan for this review. We'll kick things off with the big picture, the essentials you gotta know. Then, we'll zoom in on specific cancers. We're talking organs, blood, and bones. And finally, we'll wrap it all up by connecting the dots with the nursing priorities that really apply across the board.
Okay, before we start tackling specific cancers, we have to talk about this one core concept. Seriously, it's the common thread that ties pretty much all of pediatric oncology nursing together.
And that concept is myelosuppression. You absolutely have to understand this. See, when chemotherapy goes in to attack those fast-growing cancer cells, it can't really tell the difference, so it also hits the fast-growing cells in our bone marrow. And what does that lead to? It leads to the three biggest risks for our patients: infection because of low white blood cells, bleeding from low platelets, and just profound fatigue from anemia.
All right, let's jump into our first set of specific cancers. Now, these two abdominal tumors are super high yield for your exam, and trust me, knowing how to tell them apart is absolutely critical. So when you see a test question, and it's describing a toddler or preschooler with this firm, painless mass on one side of their abdomen, your brain should just immediately scream, "Wilms tumor!" That is the absolute classic presentation.
And this brings us right back to that question from the beginning. So you've identified a potential Wilms tumor. As the nurse, what is your absolute #1 priority?
This is it. Put a huge mental star next to this one. You do not, under any circumstances, palpate the abdomen. The reason is this tumor is encapsulated, kind of like it's in a fragile little bag. If you push on it, you could cause it to rupture, spreading cancer cells all over the body. This is a massive safety point and, yeah, a total favorite ATI question.
Okay, now for the other big abdominal tumor you need to know. Neuroblastoma. This one typically starts in the adrenal gland, which sits right on top of the kidney. Now, here's the key difference. While a Wilms tumor is often found as a nice, contained mass, neuroblastoma is, well, it's sneaky. It is often already spread, metastasized by the time it's even diagnosed.
So you really need to pay close attention to these signs of metastasis. Yeah, the child might just look generally unwell, but the classic signs, the things that should make you think neuroblastoma are these raccoon eyes, the bruising around the eyes, and bulging eyes, what we call proptosis. That plus bone pain, those are your big telltale clues.
So, this table gives you a really clear side-by-side comparison. Let's break it down. For Wilms tumor, you're thinking kidney, and the big nursing alert is do not palpate. For neuroblastoma, you're thinking adrenal gland, and you're on the lookout for those metastatic signs, especially bone pain and those eye changes.
Okay, let's shift gears now. We're moving away from solid tumors and into the most common type of childhood cancer overall, leukemia.
That's right. Leukemia is #1, and the peak age for diagnosis, this is key to remember, is between 2 and 5 years old. The most common type is acute lymphoid leukemia, or ALL. And the early signs can be super vague. Maybe a low-grade fever, the kid looks kind of pale, or they're bruising a lot more easily. And why is that? It's because the bone marrow is literally getting crowded out by cancer cells, so it can't make the healthy cells it's supposed to. Now, treatment for leukemia, it's a marathon, not a sprint, and it happens in these distinct phases. First, you have induction. This is a really intense phase to get the patient into remission. Then there's intensification or consolidation therapy, which is designed to hit any of those sneaky leftover cells. And finally, there's a long maintenance phase to keep that cancer from ever coming back. All right, let's move on to our final category of cancers for this review. We're talking about those affecting bone and soft tissue. And you'll see these often pop up during the teenage years, right when kids are hitting those major growth spurts. Okay, the two big ones you've got to know here are osteosarcoma and Ewing sarcoma. Notice the difference in location. Osteosarcoma is usually at the end of long bones, while Ewing's is in the shaft. But here is the absolutely crucial point for your exam. Look at the treatment. For Ewing sarcoma, think radiation. Amputation is not the standard treatment, which is a big contrast to osteosarcoma, where it's often a primary option.
And speaking of amputation for osteosarcoma, there's a critical nursing point you have to remember, and that's phantom limb pain. Please remember this is not just in their head. It is a very real neuropathic pain that needs to be assessed and managed properly, often with medications you might not expect, like certain antidepressants.
And now we circle right back to where we started. See? All of these cancers we've talked about are treated with chemotherapy, and that means all of these patients are at risk for myelosuppression. This right here, this is where your nursing skills truly shine.
So, I want you to burn this triad into your memory. You have low white blood cells, which we call neutropenia, and that leads to a massive risk for infection. You have low platelets, or thrombocytopenia, which means a huge risk for serious bleeding. And then you have low red blood cells, which causes anemia and that debilitating fatigue.
And this slide basically lays out your action plan. It's what you do about those risks. For neutropenia, you're on infection watch. For thrombocytopenia, you are on bleed watch. And for anemia, your main goal is energy conservation. These are your core responsibilities, day in and day out. Now, of these three problems, infection is the most immediate, life-threatening risk. A fever in a neutropenic child is not something you wait on. It is a medical emergency. You're going to be monitoring their temperature like a hawk, practicing meticulous hand hygiene, and teaching the family why they have to avoid crowds and anyone who's sick. All right, priority number 2 is bleeding. This means you're putting specific precautions in place. We're talking no rectal temps, avoiding any unnecessary needle sticks, using a soft toothbrush, and constantly scanning for any signs of bleeding, like those little pinpoint petechia or new bruises. And finally, we have managing anemia. And this is all about protecting that child's incredibly limited energy. So you'll do things like cluster your nursing care, doing as much as you can at once so they can rest. You'll enforce quiet times and rest periods, and you'll help the family understand why their child is just so tired. It's all about maximizing their quality of life through a really tough treatment.
So, we've covered a ton of the critical pathophysiology and the nursing actions you need for your exam, but I want to leave you with this final thought. Your role as a nurse goes so much deeper than just the physical care. A cancer diagnosis is a traumatic event for the entire family. Providing that emotional support, giving them clear education they can understand, and connecting them with resources, that is just as important as managing chemo side effects. And that is the true art of pediatric nursing.